Miss DSSA, 18 years old female patient, single, born and lives in Giza, Egypt, student, right-handed with regular menstrual cycle. Complaint, inability to walk properly. الفامily pedigree, positive consanguinity, and mother and father are cousins. A younger sister has the same symptoms as our patient. All others, their sisters and the only brother are okay. Family history irrelevant. Past history.
الريليفنت ازاي؟ الحاجات دي
عندنا-
بندي فيها بيج زيرو. الريليفنت ازاي؟ امسحيها بسرعه.
حاضر.
هتجننوني.
هر-
يلا.
Developmental, delayed walking. She started walking at 1 year and 10 months. The speech normal development. The sphincters, she achieved continence at 3 years. IQ with mild intellectual disability. Also, the patient had since birth multiple chest infections till 1.5 years with multiple hospital admission. Medical, no fever, fits, or neurological importance. Surgical tonsillectomy done at age of 7 years. History of present illness, gradual onset, progressive course since the start of walking at 1 year and 10 months. The condition started since the start of walking with delayed walking, where the patient was noticed to have frequent falling and difficulty in climbing and going down the stairs. Later on, at the age of 4 years, she had bilateral lower limb distal weakness in the form of difficulty in wearing shoes and slippage of shoes from her foot. At the age of 8 years, she was noticed to have tiptoeing at walking. At the age of 13 years, a mother noticed deformity in both distal lower limbs with edema in toes. At the age of 14 years, atrophy was noticed at both upper limbs distally with the inability to grasp a pen and write properly. Along with atrophy in both lower limbs distally, changes in the shape of toes and mild foot drop. Also, she was noticed to have decrease in pain and temperature sensation in both extremities, where she had multiple unnoticed cuts in her hands while using knife and multiple bruises on her foot and ankle. The patient doesn't know how they happened. At the age of 16 years, she started to have tremors in both upper limbs while outstretching her arms and cramps in both lower limbs, mainly thigh calf muscles, along with low back pain. Throughout the history, no other motor, sensory, cranial nerve, sphincteric, autonomic, or any disturbance in conscious level or phase. General examination, patient was vitally stable, no lymphadenopathy with audible heart sounds and a lax abdomen. Neurological examination, the only affected was cranial nerve, the 12th cranial nerve with tongue fasciculation.
Tongue fasciculation only, or there is atrophy and weakness also?
لا, only tongue fasciculations. State, senar, hyposenar, lumbrical and interossei atrophy and guttering, hammer toes in both lower limbs, high arched foot, no fasciculations, except the tongue fasciculation. Power, bilateral upper limb and lower limb weakness, distal more than proximal, with slender hand, weakness in the interossei and lumbricals. Extensors of the forearm are affected more than the flexors, and adductors equal at the abductors. Lower limb, distal more than proximal, dorsiflexion affected more than the plantar flexion with foot drop. The hip flexors are affected more than the extensors. Reflexes, lost reflexes of both upper limbs. Knee reflex is intact bilaterally and ankle reflex is lost with bilateral extensor plantar reflexes.
Extensor plantar, is it true or it is false? Because you have weakness of dorsiflexors.
Yes,
And
but with
although
extensor plantar.
With extensor plantar, it was
Yes.
severe or mild weakness?
Mild foot drop, mild.
Okay.
Gait, tiptoeing, sensory examination, we have high glove and stocking, till mid forearm and just below knee. Vibration not affected. Differential diagnosis, my first differential diagnosis would be Charcot-Marie-Tooth. Maybe
Motor
mitochondrial.
وسنسوري.
Yes.
ايه اللي حط السباينال ده فوق؟
The first one would be Charcot-Marie-Tooth. Maybe mitochondrial or peroxisomal. Distal spinal muscle atrophy will not be the first one.
Okay.
Investigation, ESR is 30, CPK is 195, mildly elevated. Nerve conduction and velocity showing chronic mixed polyneuropathy, more in the lower limbs, mainly motor affection and neuropathic pattern in an EMG. The echo is normal. The whole exome sequencing is showing homozygous variant and an SIGMR1 gene associated with distal spinal muscular atrophy type 2, yet it's not significant.
Okay. So Nuran is introducing this patient to take your لا خلي لنا التحليل الجيني to take your opinion in this mutation because she was going that this is a mixed sensory and motor polyneuropathy and manifestation looks like Charcot
Charcot
Marie
Marie-Tooth.
and two patients in the same family affected
Yes, here and
with
her younger
positive
sister.
consanguinity.
Yes.
So the family history is relevant, not irrelevant.
Yes.
And nerve conduction was of
Neuropathic.
polyneuropathy, mixed axonal. It is axonal or demyelinating?
She have two nerve conduction. One of them axonal and another one mixed axonal and
Okay.
demyelinated.
One is axonal and one is axonal, mixed axonal demyelination, but it is motor and sensory. And this mutation, show us the mutation. What's your opinion? It is SIGMAR1 gene. Unclear result, but they said that it could be with distal spinal muscular atrophy type 2.
So I think you need to verify the segregation in the parents. The sister has exactly the same variant.
And the same variant نفس
They
الفينوتايب.
both have the same.
The sister was not investigated.
Okay,
Yet clinically,
so-
she have
Clinically.
tiptoeing.
Clinically tiptoeing.
So you need to check if she has the same. And then I don't know this gene very well, so but we need to check with the
Check
prediction like yeah, the genotype phenotype correlation. But if she's biallelic, homozygous, and the segregation is confirmed, I think it could correspond well with the phenotype. Huh? And you have overlap with the distal spinal muscular atrophy and
And Charcot
hereditary polyneuropathies, so it could be in favor. Try to check in the literature what is described.
شفت الجين ده قبل كده حضرتك؟ ورينا بقيه الريبورت. معاكي التحليل الجيني يا ماما؟ هاتي. She has a report. give to دي الدكتوره نرمين. بيبقوا كاتبين يعني. خلاص اقعدي يا حبيبتي. يعني حتى لما يطلع لك الهول اكزوم بنتيجه you must be sure that this is a cause because after that there will be genetic counseling الفاميلي therapies we must be sure what is the result. هو very rare gene mutation الحقيقة. I didn't hear about it before.
Distal hereditary motor neuropathy.
It can cause both motor neuropathy
yeah. Encodes a non-opioid endoplasmic reticulum protein, which is involved in a large diversity of cell function. It's expressed ubiquitously. It has been described in juvenile amyotrophic lateral sclerosis and distal hereditary motor neuropathies. Distal weakness and atrophy beginning in childhood and slowly progressive in the first 2 decades of life. Severe muscle wasting and weakness with distal lower and upper limbs with claw ends, foot drop, and equinovarus deformity and hammer toes.